Hi everyone, can you hear me?
Yep, we can hear you. Okay.
Cool. And I hope you can see my screen as well. I'm Tom, I'm one of the interns at Carlin, and I'm going to give you a talk on Hep Bill today. Some of the sort of higher yield topics for your OSCEs and exams just to prepare. Because there's so few of us, and I've actually written quite a lot of case studies, and I was hoping to run this as a sort of very interactive session anyway. I would appreciate it if you wouldn't mind, you don't have to, of course, turning on your cameras and sort of interacting as much as you can, because I think that this could be a really good session to prepare for your OSCEs and everything as well. Cool. Thanks, Elise and team. So the three main topics that we're going to cover today are pancreatitis, gallstone disease, and pancreatic cancer. The other two main topics that I saw that were in your objectives were cirrhosis, I think, and then there was something else also. And I think that they're probably more medical topics, but I haven't really covered them as much in this. And the other one was liver lesions, which I don't think was really covered as much in the curriculum when I was in fourth year either. Oh, we've got a little one too. So the first clinical vignette, if somebody wants to volunteer to sort of take a bit of a history from me and say what you'd find on examination in this case. So we've got a 42-year-old female who presents with a 12-hour history of severe and worsening abdominal pain. She looks dehydrated and unwell. Would anybody like to volunteer to take a bit of a history? No? Does Elise's team want to try?
Yeah, we can give it a go.
Oh, I can't quite hear. Hang on, let me turn on I think my volume is down.
Sorry.
All right, I think that's got it. I think I can hear you now. Go ahead.
Okay. Where is this abdominal pain on in your stomach?
So it's really high up, right underneath, sort of under the sternum, under the rib cage.
Has it been there the whole time or has it moved?
No, it's been there the whole time.
Okay. Could you describe this pain?
It's sort of like a sharp searing pain.
Okay. And were you doing anything when the pain came on?
No, not really. It just came on suddenly.
You hadn't just eaten anything in particular?
No, not in particular.
Okay. Is anything making this pain better?
I think it probably gets a little bit better if I sit forward.
Okay. And have you had this pain before?
I've had two sort of similar episodes of this pain, yeah.
Okay. Were they as severe as this?
Not quite as bad, but still pretty bad.
Okay.
Yeah.
Have you noticed any sort of really dark stools recently?
No, I haven't.
Have you been nauseous or vomiting at all?
Yeah, I have been nauseous, but I haven't been vomiting at all.
Have you been feeling feverish at all with hot or cold? Like
Not really, no.
Have you been passing your bowels?
Yeah, there's been no changes there at all.
Changes, okay. Do you have any other past medical history?
So I have had acute pancreatitis twice before, once in 2018 and once in 2020.
Okay.
But nothing else really.
Have you had any previous surgeries?
No.
No, okay. So gallbladder's still in?
Yeah, I've still got my gallbladder and everything, yeah.
Cool. Are you on any blood thinners?
No, good question. I'm not.
When was the last time you had a meal?
Oh, I really haven't been hungry for the last 12 hours or so, so probably not since last night.
Okay.
Mm.
Do you have any allergies?
No.
Do you smoke?
Yeah, about 30 a day.
30 a day. Okay.
Yeah.
You drink any alcohol?
Yeah, a bit, I think.
Okay. How much would you say you have? How many standards would you have in a week?
Oh, I don't know, but I drink about 1 liter of vodka a day.
Liter of vodka a day. And were you drinking last night as well?
Yeah, I drink throughout the day, every day. Yeah.
Yeah. Any recreational drug use?
Yeah, I use a bit of meth.
Do you have anything that runs in your family?
Not really, no.
No.
Cool. Any other questions? I think you guys have done a pretty good job. Yeah. Anybody else have anything they wanted to add? No, that's all good. No, I think you guys did a really good job, really good pain history. The only thing I would suggest is maybe like you could start with some open questions as well at the beginning to say, can you tell me what's going on? But I think in an OSCE situation as well, sometimes it can just be easier to go in directly with the questions as also. Yeah, you characterize pain very well. The only thing I would have added is maybe sort of like weight loss, lethargy, sort of some of those constitutional symptoms. But yeah, otherwise, I've found with Melina as well, sometimes it's really useful to just specifically ask patients, have you had specifically any black, tarry, sticky, smelly stools? Because sometimes they'll say, oh yeah, I've had some dark bowel motions, and then you sort of delve into it a bit further, and actually it's just sort of a dark stool rather than a pitch black sort of stool. It was really good how you sort of teased out the actual amount of alcohol I drink as well, so that was good. So if we move on to examination, what do we think the most likely diagnosis is first? And then we can sort of figure out what we might find on examination from there.
Acute pancreatitis.
Yeah, definitely. Probably related to, well, almost certainly related to alcohol. And actually seeing patients who drink this much alcohol is not uncommon at all. I've just come off of ED, and people are frequently drinking, 3 or 4 liters of wine a day, plus 1 liter of vodka, plus some whiskey. People drink a lot of alcohol. So on general inspection, I'm sort of laying in the bed. With anybody with pancreatitis, it's really important to check fluid status as well. So you really want to do a proper fluid balance assessment. Does anybody know some of the signs that you would look for to see what my fluid status is?
Skin turgor, dry mucous membranes.
Yep.
You check the pulse. The dehydrated might be tachycardic.
Yeah, very good. Anything else?
Urine output?
Yeah, very good. What's the minimum urine output we want? If you just keep in your mind, 0.5 ml per kilogram per hour is normal urine output, or your bare minimum urine output that you want to tolerate in somebody. Okay, so if you keep that in the back of your mind, 0.5 of a ml per kilogram per hour, that'll sort of stand you in good stead. And the other thing for fluid balance, obviously, is to look at blood pressure as well. Look at peripheral perfusion. So you feel the peripheries. You want to make sure that they're warm. You want to check that the pulse, you've sort of mentioned, is regular, but also whether it's palpable and where it's palpable. If I don't have radial pulses or I don't have brachial pulses, it probably means that my blood pressure is not more than 80. So that sort of gives you some more cause for concern. In the chest, my heart sounds are dual and there's no murmurs. The chest is clear, but my abdomen is very, very diffusely tender, but particularly painful in the epigastrium. And my abdomen is also distended with reduced bowel sounds. Does anybody know why the bowel sounds might be reduced?
Do you have an eyelid?
Yeah, exactly. So with any sort of inflammatory condition of the abdomen, whether it's sort of a surgical thing, or whether it's an inflammatory condition like pancreatitis, you can get an ileus as well, which is essentially a sort of non-structural bowel obstruction. So yeah, correct. And I'm not jaundiced, and there's no Cullen's or Gray Turner signs either, so you're not sort of suspecting a retroperitoneal hemorrhage. All right. An easy way to remember Cullen's or Gray Turners, if you get them confused, is that Cullen's is one word. It happens around the umbilicus in one spot, whereas Gray Turners happens in 2 spots in both flanks. So that's how you can remember them if you struggle. Does anybody have any suggestions about what investigations they'd want to do?
Well, you'd want to do a raft of things. See You
Yeah,
want to get lipase, EUC, especially if they're dehydrated.
yeah.
CRP,
Mhm.
LFTs.
Yeah.
Normal CBE to look at infections and those sort of things, or if there's bleeding.
Yeah, very good. And what would you expect to see on some of these? Because in the OSCE, you'll get extra points if you say, I want a CBE to look for, I want a CRP to look for. Like, what would you expect the findings would be?
So on CBE, we'd expect hemoglobin to be normal, maybe slightly elevated white cells, but not indicative of a bacterial infection. We'd expect CRP to be elevated. In LFTs, if this is primarily due to alcohol, we wouldn't see necessarily we wouldn't see an obstructive picture.
Yeah.
Lipase would be 3 times the upper limit of normal.
Yeah, very good. And what's an essential test that we have to do in this person?
Ethanol,
What was that, sorry?
blood ethanol content.
Yeah, definitely. You could do one of those. But
Beta
something
HCG.
beta HCG, absolutely. Because she's 42 years old, she's female, you have to exclude pregnancy because she's got abdominal pain. Okay. So yeah, definitely. The other things that you could definitely consider ordering are calcium as well, because particularly in severe pancreatitis, you can get hypocalcemic. You can get hypocalcemic and sometimes quite severely because you form soaps in the pancreas. And the other thing is triglycerides as well, if you're suspecting that it's a hypertriglyceridemia related pancreatitis. And then the other thing that you could do is some imaging, so an abdominal ultrasound, and that's probably to look for any stones or anything like that as well. Okay. Does anybody, maybe somebody else we might pick on, have any other differentials for what this could be?
I didn't hear the start of the history, but it could be like a perforated peptic ulcer.
Yeah, definitely. Yeah, that's a really good differential. So with anything epigastric, you always think about, I find it easier to just think about what structures are in that particular area. So you've got the stomach, you've got the duodenum, you've got the gallbladder and the pancreas, and also the aorta. So there's a various number of structures there that could be damaged. And I will take you through a full list that I put together a little bit earlier. But first I wanted to take you through some LFTs as well, because Stephen mentioned that this would maybe be a good idea. This is from some slides that I did for a MedShoots lecture a couple of years ago. So, and you'll get all of the slides as well. I'll send them through to Siva. So your main LFTs that you look at are these ones. And the only one that doesn't come in the standard panel is coagulation studies. So albumin is a marker of hepatic synthesis. And it's decreased in a range of different disorders. So if you've got cirrhosis, you don't actually have the hepatocytes to make albumin. So that obviously decreases your albumin level. If you're malnourished or if you've got protein loss for some reason, that can also result in decreased albumin. The other thing about albumin is it's actually a negative acute phase reactant. So when you've got an acute inflammatory process, albumin actually decreases. So it's kind of the opposite effect to CRP or ESR or those other ones. Coagulation is a marker of hepatic function as well, just because the liver makes all of your coagulation factors. If you're looking for hepatocellular damage, you want to look at ALT and AST in particular. ALT is the more specific marker because AST also comes from other areas of the body. And generally, sort of, if you have a really, really high ALT or AST, then that's quite concerning for liver damage itself. And then your cholestatic LFTs are your ALP and your GGT as well. If you just have ALP raised by itself, then you can't really guarantee that it's coming from the liver. It might be coming from the bone, and you might need to look for bony disease instead. Something useful to know when you're interpreting LFTs as well is the AST to ALT ratio. With most hepatocellular injury, ALT will be higher, but in alcohol-related disease, the AST to ALT ratio might be 2 to 1. And it's particularly so if the GGT is also elevated, because alcohol by itself will increase GGT. And especially then if you look at the CBE and see that you've got a macrocytic anemia, that's also particularly associated with alcohol use also. And it's actually quite common just to see an isolated elevated GGT as well in patients, and it can sort of give you a bit of a clue to the fact that they're sort of relatively heavy drinkers. And I don't know if Dr. Penelope Coates ever gave you your lecture about LFTs, but something that's always stuck with me from her lectures is that very, very high AST and ALT levels up into the thousands. Generally, there's only 3 things that can really cause LFT elevation of that degree, and it's ischemia, toxins, or acute viral illness. But then if the AST and ALT levels are lower, you have to consider sort of a broader differential generally. So your differential for the causes of this lady's presentation are quite varied. The most common is going to be gallstones. It causes 40 to 70% of cases. And then ethanol as well, which is particularly common. I did Gen Search earlier this year, and we had a lot of cases of ethanol-related pancreatitis, and a lot of them were quite severe cases as well. A large proportion of the patients are going to have idiopathic pancreatitis, and that's where sort of there's extensively investigated, but a cause is never found. And then there's rarer things as well. There's direct traumatic injury to the pancreas, mumps and various other viruses. I've never seen a case of mumps. Scorpion bites don't happen really. And then hypertriglyceridemia, but it really has to be above 11 millimoles per litre. Another pretty common cause is post-ERCP as well. 3% rate post a diagnostic ERCP and a 5% rate post a therapeutic ERCP. And then if all other causes are sort of ruled out, you have to consider whether drugs might be responsible or whether an autoimmune or genetic illness might be responsible as well. The PRSS1 associated pancreatitis is autosomal dominant, and then CFTR, so in cystic fibrosis, is obviously autosomal recessive. In order to diagnose acute pancreatitis clinically, basically all you need is 1 and 2. So if you have a clinical picture that's very consistent with acute pancreatitis, plus an elevated serum lipase to at least 3 times the upper limit of normal, you can confidently diagnose acute pancreatitis without doing any imaging whatsoever. When you would do imaging, basically, is if these top 2 criteria aren't satisfied, or if the diagnosis is a bit uncertain, or if the patient's just not improving after 3 to 5 days and you need to make sure that they don't have pancreatic necrosis or something like that. Generally, if in the emergency department or on the wards, if you're going to do imaging for suspected pancreatitis, the first line would be contrast enhanced CT, which is generally what you do for any sort of acute abdomen if you can't really diagnose it clinically. Or second line is abdominal MRI, and that's if there's a contrast allergy or sort of renal failure that precludes you from giving contrast. Generally, you can give contrast if the eGFR is above 30 though. Does that make sense? Yep. Further evaluation, we've already sort of gone through all of this. And then if the above fails to identify the cause, then there's always more imaging that you can do and further investigations as well. And as I mentioned, the differential diagnosis for acute sort of particularly upper abdominal pain is quite broad. I think Marcy mentioned a perforated peptic ulcer. Also consider other gallstone disease that can cause epigastric pain that's sort of right upper quadrant, sort of sitting between a perforated viscous. Hepatitis, GORD, or chronic pancreatitis as well can cause epigastric pain. You always want to keep in the back of your mind like a vascular emergency, like an aortic dissection or an abdominal aortic aneurysm, or mesenteric ischemia as well. But obviously these all present slightly differently. If the pain is sort of very high in the epigastrium tending towards the chest, you need to think of chest causes as well, things like a pneumonia or a pneumothorax, ischemic chest pain, PE or pericarditis. And just remember that there are always other causes like reproductive, particularly in the upper quadrants. A perihepatitis related to PID, it's called Fitzhugh-Curtis syndrome. You may have, I don't know if any of you have read about it, but it's it can happen and it can cause sort of right upper quadrant / epigastric pain as well. So there's 2 main categories of acute pancreatitis. There's acute interstitial edematous pancreatitis, which is most cases, and then necrotizing. Overall, the mortality is less than 5%, but it's obviously higher if people have parts of their pancreas which have died. And then most people have sort of mild disease and it doesn't really cause any complications. In terms of natural history, there's always a risk of recurrent attacks, particularly I would say in this lady, if she keeps drinking a litre of vodka a day, then there would be a risk of recurrent attacks and eventual development of chronic pancreatitis as well. And something that can come up in exams are these complications of acute pancreatitis as well, which when I was doing SHU, I found this very confusing. But basically, the top two, acute peripancreatic fluid collection and pancreatic pseudocyst, are complications of this type of pancreatitis, acute interstitial edematous pancreatitis. And the second two, acute necrotic collection and walled-off necrosis, are complications of necrotizing pancreatitis. If it has acute in the name, it occurs less than 4 weeks. And then if it's got a more organized structure, so if it's walled off like a cyst or a walled off necrosis, then that takes time. So that's more than 4 weeks. And if in necrotizing pancreatitis, there's a risk of infection because you've got dead tissue in the abdomen that can become colonized with bacteria. And if there's an infection in dead tissue, it needs to be debrided generally. Does that make sense in terms of the complications of pancreatitis? Yeah. And then there's the systemic complications, which is where the mortality happens sort of acutely. So if somebody's quite comorbid, they've got underlying cardiovascular disease or heart failure, and they come in with acute pancreatitis, that can cause acute decompensation of their underlying disease. And so you can have mortality that way. Or it's a very inflammatory condition and you can get activation of all these cytokines, which leads to a SIRS response and multiple organ failure as well. This is just for your reading later. One thing that also confused me about acute pancreatitis is grading its severity, because we sort of learned about all of these different severity scores and things. But really what I've read in this is that basically none of them are recommended individually to grade the severity. So the Glasgow, the Ranson and the Apache 2, they can be useful, but generally there's a delay before you can actually apply the scores, generally of 48 hours. And what I've actually never seen them applied in hospital in any of the pancreatitis cases that I've looked after. Generally, it's sort of a holistic look at, you know, how old is the patient? What are their comorbidities? How likely are they to get really sick from this pancreatitis? And you sort of put all that information together to determine what the severity is. But the guidelines, I think it's the Atlanta classification, categorizes it like this. So mild is no organ failure or no complications. Moderate is transient organ failure, less than 48 hours in duration, or local or systemic complications without persistent organ failure. And then severe is obviously persistent organ failure. So in terms of how to answer a question in an OSCE or an exam about what you do for acute pancreatitis, one of the first things that you need to consider is how sick is the patient and do they need a review or an admission to ICU? When I was on Surge earlier this year, there were a few patients who were very sick. There's one in particular who actually had an alcoholic pancreatitis, so I based this case on, who was very, very unwell, was sort of persistently hypotensive on the ward, had all of these different electrolyte abnormalities. We were having to replace calcium on the ward, all sorts of things. And in the end, the severity was such that she had to go to ICU. The main early management is aggressive fluid resuscitation. And you do this with an isotonic crystalloid, usually normal saline, but you can also use Hartmann's. And then you need to really carefully assess fluid balance and make sure that they're firstly not getting overloaded, particularly in a comorbid patient, but then also to make sure that their urine output is adequate and that they're meeting their targets and all of those sorts of things. The pain in acute pancreatitis can be very severe. Sometimes you can manage it with oral opioids, but quite often you need to get the acute pain service involved for intravenous analgesia. You need to carefully monitor the patient. When it comes to feeding, people with mild pancreatitis, you keep them nil by mouth. And then gradually what you do after the pain and the nausea and vomiting start to improve, you gradually up titrate the diet. So what would happen is generally they start on clear fluids, which is water, clear cordials and juices and broth. And then you might move them to free fluids, which includes things like custards and yogurts and those sorts of things. And then you gradually increase as tolerated. But if the pancreatitis is severe and the patient's not going to be able to tolerate the oral intake for, you know, over a week, then you need to consider enteral nutrition, which is a tube down the nose into the either stomach or the jejunum, and just delivering enteral nutrition that way. The patient may need an ERCP if there's gallstones or if there's cholangitis at the same time. And generally, if there's gallstone pancreatitis, they're going to need a lap chole as well. And sort of question that catches people out a lot of the time is antibiotics as well. Antibiotics are not routinely recommended as prophylaxis for acute pancreatitis because it doesn't actually do anything. If there's evidence of an actual infection, then for sure go for your life, give antibiotics. But if there's no infection, there's no point. So don't do it. And then in this patient, there's a whole bunch of other, she's quite complex. She's got a lot of other issues. So if you were the intern on the ward looking after this patient, you wouldn't just manage her pancreatitis, but you also need to consider the very real possibility of alcohol withdrawal. You don't want to precipitate Wernicke's encephalopathy, so you need to give thiamine and multivitamins as well. If the patient's willing, you might consider referring them to DASA. She's an IV drug user, so you might want to consider bloodborne virus screening. VTE prophylaxis is really important as well. You don't want her to get a PE. And you need to make sure any regular medications are charted as well. So these are sort of things that you would think about as the intern if you were looking after them. Any questions before we move on? No? Cool. We'll move on to gallstones now. So this is another case. So I'm going to nominate somebody to take a history. If nobody volunteers within 10 seconds, that's okay. So case 1, does somebody want to take a history? This is a case of a 45-year-old female called Fiona who presents to ED with intense right upper quadrant pain. She's got a history of GORD, PCOS and depression. She's had 2 C-sections in the past and she's on metformin and escitalopram. Sebastian, do you want to take a history?
Sure.
Cool.
All
Thank
right. So can you tell me a little bit more about what's going on?
Yeah, so I've just been having this pain right up high in the right side of my abdomen. It's under the ribs. I've had a couple of similar things in the past 6 months, but this is definitely the worst one.
Mm-hmm.
Yeah.
Mm-hmm. And the previous episodes, did they just go away on their own or did you come into the hospital as well?
No, they just went away on their own. Generally, they sort of go away within about 4 hours, but this one's been going on for much longer. We're sort of at the 5-hour mark now.
Yeah. Can you describe the pain for me?
Yeah, it's sort of like a dull, sort of just annoying pain, but it's really, really intense.
Mm-hmm. Mm-hmm.
Yeah.
Does it come and go or is it there all the time?
No, it's there all the time.
Yep. And if you had to rate it out of 10, what would you put it at?
Probably a 7.
Yep.
Yeah.
Does anything make this pain better?
No, nothing.
Anything make it worse?
No.
Were you doing anything in particular when it came on? Were you exercising, eating, or?
I was actually at Macca's eating, having a Big Mac.
Mm-hmm, mm-hmm.
Mm.
And did it come on suddenly or gradually?
Oh, probably like 20 to 30 minutes after I finished at Macca's. Yeah.
Yeah. And is it getting worse or is it about staying the same?
It's pretty much staying the same. Yeah.
Yeah. How do you feel otherwise?
Yeah, pretty well. Look, I'm a bit nauseous, to be honest.
Yeah. Have you vomited at all?
No, I haven't vomited, but yeah, otherwise I'm feeling pretty good.
Yeah. Are you feverish?
No.
No. And do you have any medical conditions?
Just the ones there. I've got polycystic ovaries and depression and stuff I've been struggling with, but apart from that, I'm all right.
Yep. Okay. And are you otherwise fit and healthy? Do you exercise much or?
Oh, to be honest, I could probably exercise a bit more.
And your diet, do you often have Maccas and stuff like that or?
Yeah, every few days. Sort of.
Yeah. Cool. All right. Well, I think you've got some acute cholecystitis.
Okay.
Oh, actually, are you yellow at all? Has anyone said you're yellow? I'd look to see.
No, I haven't. I don't think I'm yellow. No.
Yeah.
No,
Cool.
I looked at myself this morning. I thought I looked okay.
Well, I'd look at you as well if I was there.
Yeah, definitely. Yeah, good. And what would you want to look at on examination?
So I guess vitals, see how the patient is sort of systemically, as well as abdominal exam, seeing if there's tenderness in the upper quadrant or generalized tenderness as well. And seeing abdominal tenderness, pain, guarding.
Yep. So my vitals, I'll actually bring them up. Actually, just before we do that, I'll just tell you my vitals are all fine. I'm afebrile. My cardiovascular and respiratory system are normal, and my abdomen is soft and non-tender, so there's no tenderness anywhere at all. What bloods would you want?
Basic blood, CBE and EUC, as well as LFTs.
Yeah. And what would you want to, what's your rationale for?
I guess CBE and stuff is more just general marker of health and inflammation as well, if we're thinking anything infective causes. And then I guess they said they're nauseous, but I haven't been vomiting. So I guess you're not really thinking of electrolyte stuff. And then LFTs, just if we're thinking about anything involving the liver or the gallbladder, seeing what levels are there.
Cool. And what other essential test do you need to do?
Oh, you're a female. Oh, right. Yes.
Yeah.
I'll do a beta HCG.
Yes, good. Never forget that one. Cool. So this is the examination. It's all pretty normal. There's no leukocytosis on the CBE. My electrolytes are normal. There's no abnormality on the LFTs either. So particularly there's no obstructive picture. My HCG is negative, and I also ordered a lipase, which was negative.
Sorry,
So
just
what's your-
is Murphy's sign positive or?
Murphy's sign? No. So there's no Murphy's sign. Yeah. Good thought. So what do you think is the most likely diagnosis?
Biliary colic.
Yeah.
Yeah,
Biliary colic.
good. Yeah, definitely. So it's biliary colic secondary to cholelithiasis. So generally with biliary colic, you get normal bloods. You just get these sort of onset of pain, and it's representative of stones which exist in the gallbladder being pushed up into the cystic duct when the gallbladder contracts after a meal, and it just increases your pressure inside the gallbladder and causes pain. And despite it being called a colic, it's generally a constant pain rather than a wave pain. And there's no reason to think that she has sort of cholecystitis or anything like that, because she's afebrile. She examines well. There's no Murphy's sign, and there's no evidence of inflammation on the CBE. So that's very good. And you explored the possibility of jaundice as well, because you always need to consider that in this case if you're thinking of biliary obstruction. Cool. So we've got another case. This one's of Marcus, who's a 32-year-old male who presented to ED with right upper quadrant abdominal pain and jaundice. He has a history of asthma, past surgical history of testicular torsion at 13 years old, and a lap cholecystectomy in March of this year, sorry. And he only takes salbutamol as needed. Does anybody want to give this one a go? Shall I pick someone? Jermaine, do you want to give it a go?
I think I want to ask about whether this abdominal pain has happened before.
Yeah. Let me just, yeah, so I've had 3 episodes of this sort of pain in the last 12 months.
All right, and how long has this pain been going on for?
So this particular episode of pain has been going for about 12 hours now. It's just not going away.
Was there anything that triggered it?
Not really. It just came on last night.
Is there pain? Do you feel pain anywhere else?
There's a bit of pain in my right shoulder blade, actually. Yeah.
And how will you describe the pain? Sharp or dull?
Probably sharp. Yeah.
Are you experiencing any other symptoms like fever?
No, I haven't had any fever.
Night sweats?
No.
No. Any weight loss recently?
None.
No. So is the pain constant throughout?
Yeah, it's pretty constant actually. Yeah.
Okay. And for the jaundice, how long has it been? How long have you noticed that you're being a bit yellow?
Yeah, probably since this morning. I think the pain came on last night, and then I got up this morning still in pain, and I just looked in the mirror and I sort of thought that I was a bit jaundiced. Yeah.
All right. Have you had any nausea or like vomiting?
Yeah, I've been vomiting today. I've vomited probably 3 or 4 times.
Yeah. Do you know what the contents are? Is it food? Is there any yellow content?
It's just food, yeah.
Food. All right.
Yeah.
And maybe just to ask a bit about your social history. Do you drink alcohol?
No, not really.
Or do you smoke?
No.
No. All right. Yeah. I don't really have any more questions actually.
Yeah, no, that's good. Look, I know that I'm putting you guys on the spot, and in the Oscar you have like a bit more time, but I just think it's good to just like get you thinking about it and stuff, and that was really good. So, yeah, so the rest of the history, you pretty much got all of it. So I've had 3 episodes of similar pain in the past 12 months, and I had a lap chole done in March of this year for this exact same issue. The pain that I usually have tends to resolve within about 4 hours, but this time it's just been going for 12. It's sharp pain, about 8 out of 10 intensity. And I've been really itchy today as well. So whenever somebody's jaundiced, just ask about itch. I have noticed that my stools have become a bit pale and my urine is a bit darker than usual as well. So on examination, this is what we find. So I'm hemodynamically normal, so there's no fever, the blood pressure and the heart rate are fine. In the abdomen, I've got a soft abdomen with a little bit of right upper quadrant tenderness, but no peritonismal guarding, and I'm obviously jaundiced as well. The investigations are the CBE is normal. The white cell count in particular is also normal. And why do we worry about the white cell count? What would be the concern if it was elevated?
Thinking either cholangitis or hepatitis?
Yeah, definitely. Yeah. The EUC is normal. The LFTs look like this. Does anybody want to tell me what they show?
An obstructive picture with the elevated GGT and ALP.
Yeah, good. Yeah, so definitely obstructive. That's very good. And you can see that the billy is up as well, which explains the jaundice. Obviously, you don't have to do a HCG in me because I'm now a male patient, and the lipase is normal and the CRP is normal as well. So what do you think the diagnosis is, Jermaine?
Just
It's a bit of a tricky one because like
yeah.
gallstone, sorry?
Yeah, no, I'm not too sure.
Yeah, that's okay. Gallstone disorders can be a bit confusing, which is why I'm sort of going through them one by one. This one's choledocholithiasis. So in this case, you've got a gallstone that has made its way from the gallbladder through the cystic duct and into the common bile duct. And it's causing obstruction of the common bile duct, but no infection. So what you get is abdominal pain, right upper quadrant abdominal pain with jaundice because you're obstructing the outflow of bile from the liver, but you don't get an inflammatory response because it's not cholangitis. So basically you can think of choledocholithiasis as a step before cholangitis. It's the same pathology, the only difference is that there's no infection. Does that make sense?
How common is choledocholithiasis without a gallbladder?
I've actually seen a couple of cases of it, which is why I put this in as a thing. So I think I've seen a couple of cases of choledocholithiasis in people who have previously had a cholecystectomy this year. And when I went to Mount Gambier for surgeon 4th year, there was also another case down there. So I mainly put it in there to make the point that the fact that a person has had a cholecystectomy doesn't exclude the possibility of a gallstone. You can actually form gallstones within the common bile duct itself, or there can be a gallstone that's sort of left over that had already made its way out of the gallbladder before you took it out and sort of just sitting there and is only now just obstructing. Does that make sense? So the main point is it's obviously much more common to get choledocholithiasis if you've got a gallbladder, but the fact that you've had your gallbladder taken out doesn't mean that that's not the diagnosis, if that makes sense. Cool? Cool, all right. We've got another case if somebody wants to volunteer. Marcy, would you like to give it a go?
Sure.
So we've got Naomi. She's a 59-year-old female who's presented to ED with right upper quadrant pain and fever. She's got a history of hypertension and high cholesterol, had a hysterectomy in 2019, and is on perindopril, amlodipine, rosuvastatin, and ezetimibe. Do you want to just give it a go and see how you go?
Yep. Hi, Naomi.
Hi, Marcy.
So tell me a little bit more about your pain at the moment.
Yeah, I've just got this really severe pain. It's right up under my ribs on the right side, and I've never really had anything like it before. And it's just been going for 7 hours, and it just keeps getting worse and worse and worse, and I can't cope with it anymore.
Okay, I'm really sorry to hear that. In terms of the pain, how would you describe it to me? Is it a sharp pain or more of a dull pain?
It's more of a sharp pain, yeah.
Okay, right. And does it go anywhere else? Does it maybe go up to your shoulder or around to your back?
Yeah, no, it definitely goes to my shoulder on the right side.
Okay, right. And how would you rate the pain out of 10?
Probably a 9.
Okay, right. And the fever, has that been over the same sort of time frame?
Yeah, probably just all day. I've just been feeling generally a bit under the weather and feverish, yeah.
Okay, right. And have you otherwise been feeling well? Have you had any nausea or vomiting?
Yeah, I've been nauseous and I've vomited 4 or 5 times.
Okay, what does the vomit look like?
It's just food that I ate last night, and then I've just been vomiting so much that it just looks like bile now. There's just not much in it.
Okay, is there any blood in the vomit?
No, there's no blood.
Okay. And how about your bowel actions? Have you noticed any changes to that?
Not really. I don't think I've been today, but like they were fine yesterday.
Okay, right.
Yeah.
And do you have any pain anywhere else?
No, I'm fine otherwise.
Okay. And other than your hysterectomy, have you had any other surgeries like your gallbladder out?
No, I've still got a gallbladder.
Okay. Guess just an ample history. When did you last eat?
Probably yesterday. Yeah.
Okay. Right. And do you have any allergies?
No.
Okay. I don't really know what else.
No,
I'd
that's
ask
good.
you.
Yeah, no, because I've already given
yeah.
some of the history up here, so you've done a really good job. Yeah,
Oh yeah,
very
have you
thorough.
looked yellow?
No,
Sorry.
no,
Okay.
I haven't. Yeah,
Thank you,
very good.
Olivia.
So yeah, no, good history. What do you think is going on just based on the history? Do you have like a theory about what's going on?
I'm thinking it could be like ascending cholangitis.
Yeah.
Because she's got the right upper quadrant pain and also a fever. So that would probably be the primary differential.
Very good.
Maybe cholecystitis potentially.
Yeah, very good. And what would you want to look for on exam, just quickly? You just had to rush it.
So yeah, I'd be looking to see if there's any sort of reproducible tenderness, see if they're clinically jaundiced. Vitals first, sorry, to see if they're hemodynamically stable or not, confirm the fever, assess also fluid status, so skin turgor, mucous membranes as well, see if there's any need for resuscitation. Yeah, that's about it. I just focus on like Murphy's sign and stuff. Yeah,
good. So excellent. That's basically everything that I would have done as well. So you can see here that she's a bit tachy. The blood pressure's fine, but she's got sort of a mild temperature as well. Cardiovascular and respiratory is fine, but she's very, very tender in the right upper quadrant with guarding. She's not jaundiced and Murphy's sign is present. On the blood says a white cell count with neutrophilia and an elevated CRP, but otherwise it's normal. So what do you think is the diagnosis here?
Cholangitis?
Yeah, good guess. I think there's a couple of what sort of Charcot's triad? What do you need for?
You need to be jaundiced.
Yeah.
Okay.
So I think, well, you don't necessarily absolutely have to be jaundiced, but I think with the normal LFTs and the absence of jaundice, I think that probably goes against the diagnosis of cholangitis a little bit.
Yeah.
you've
So
got
like
a
cholecystitis.
yeah.
Yeah.
So with Murphy's sign, with the elevated white cell count and the CRP that's up, I think that cholecystitis is probably the most likely cause. Yeah, good job. Any questions about that one? No?
Oh, actually,
Okay.
I do have a question.
Yeah.
It's a bit of a silly one maybe, but for the LFTs, what would you see in cholangitis?
In cholangitis?
Yeah.
Good question. We'll go through that one very soon.
Okay.
Yeah. But the important thing to note is that with cholecystitis, the pathology is again at the cystic duct. So you've got a stone or some sludge that's gone up and blocked the cystic duct. And then behind the duct, you just got an inflammatory response with bacterial proliferation. That's what's causing cholecystitis. So with cholecystitis, there's no LFT abnormality. That's the main sort of takeaway from that as well. But your question will definitely get answered. This is just a fourth and final case. If somebody wants to just run through it quickly. You've got Roger, who's a 74-year-old male. He presents to ED unwell with right upper quadrant pain and jaundice. He's got a past medical history of a STEMI in 2016 with a stent to his left anterior descending artery. He's got congestive heart failure, atrial fibrillation, COPD, and he's still an active smoker. He had an open appendicectomy in 1962 and had a AAA repair a few years ago. And he's on a whole raft of medications. So this patient is not only unwell, but he's also medically complex as well. All right. Does somebody want to just give a history a go? Maybe, is it Olivia or Olivia?
Yeah.
Yeah, do you want to just give it a go?
Yeah. Hi, Roger. Sorry. Give me a second. Yeah. Hi, Roger. How are you feeling today?
Oh, pretty rotten, to be honest.
Yeah. Can you tell me more about this pain that you're having?
Yeah, it's just been, I can't tell you, to be honest, how long it's been there, probably 3 or so days, but it's just getting worse and worse and worse, and I just can't take it anymore. It's probably 8 out of 10 now, and it's just sitting up there under my ribs.
Yeah, I understand. Let me just try and get a nurse to give you some pain medications while I continue to take the history.
That'd be nice, thank you.
Yeah, and can I just ask if you had a pain similar to this before the 3 days, or did it only start 3 days ago?
No, I've never had this before.
Okay, yeah. And have you felt feverish over the last 3 days?
Yeah, I've been like hot and cold for 2 days straight now.
Okay, yeah. And have you taken anything to help with the fever?
Not really. My wife suggested Panadol, but I don't believe in that.
Yeah, I understand. That's fine. And sorry, can I just ask when your jaundice started as well?
2 days as well. Yeah.
Yep, 2 days ago. And have you found that it's been significantly worsening?
Yeah, probably.
Yeah, okay.
Yeah.
Sorry, just jumping back to the pain. You said it was right under your ribs. Is it a constant pain or does it come and go?
Yeah, no, it's a constant pain.
Yeah. And have you found that it's made worse, if anything?
Not really, to be honest. It just sort of sits there.
Yeah. And does it get better with anything as well? No.
No.
Okay. Have you found that your pain is related to eating?
No, it's not. No.
No. Okay. And just to ask a few other questions. Have you found that your stools are pretty light colored, or you notice that they float?
They're not sort of floating any different, but they are a bit lighter in color. Yeah.
Okay. Yeah. And have you noticed that your urine is darker than usual?
Yeah, it is.
Yeah. Okay.
I'm actually not making much urine, to be honest.
Okay. Okay. And have you been drinking normally as well?
I've been trying, but I'm just not really. I'm just so nauseous and feeling so unwell that I just don't want to, drink very much. Yeah.
And when was your last meal?
Oh, like 2 days ago. I haven't eaten for 2 days.
Okay. And do you have any allergies?
No.
Okay. Do you think anything might have brought this up?
Not that I can think of.
Okay, sure. I'm not sure what else to ask. I think that's about it.
No, you've done a really good job. That's a very thorough history, and I really liked it. One thing that I've just thought of with this history and also the previous one is when you've got somebody who comes in feverish as well, is just to do a quick screen to exclude other causes of sepsis as well. So whenever I go and see a patient with fever, I always think about what are all the possible causes of sepsis and what can I just exclude on history. So just ask quickly, have you had any headache or neck stiffness, any sore joints, any new skin rashes that are worrying you, any sort of cough or fever or coryzal symptoms or anything like that. Just sort of go through all of the systems and think, where can you get an infection and what symptoms can I ask just to sort of reduce the likelihood of that. You can ask about dysuria and things as well, but I haven't had any of that. So it's just this right upper quadrant pain and jaundice and the fever. What did you want to look for on examination?
I guess tenderness, right upper quadrant tenderness, jaundice, you might be a bit tachycardic.
Yeah.
You possibly might have altered mental status.
Yeah, very good.
Get your hydration status as well.
Yeah, excellent. So you've said everything correctly. My heart rate's 135 and irregularly irregular, so I'm in AF at the moment. My blood pressure is not great. My oxygen stats are not great, and I'm on 2 litres of oxygen, which given my COPD is not surprising. And I'm pretty febrile at 39.1. My GCS is also 14, so I'm a V4, which means I'm disoriented. And his wife is there as well, and says that it's not his baseline. He's usually very with it. I've got reduced air entry throughout the chest with scattered wheeze, but nil evidence of consolidation. My heart sounds a dual with a pansystolic murmur in the mitral region, which you ask the wife, it's been there for ages, so it's not a new murmur. I'm jaundiced and very tender in the right upper quadrant. So this examination is quite concerning because not only have you got Charcot's triad, which is right upper quadrant pain, jaundice and fever, but you've also got hypotension and altered mental status as well, which rounds out Raynaud's pentad as well, which is the classic signs of ascending cholangitis, which I think you probably all deduced was this case. On the bloods, so I've got an elevated white cell count with neutrophilia, which is concerning for bacterial infection. Not only that, I've got a creatinine of 250 as well, which when you look back through EPAS and assay pathology, I've never had a creatinine that bad before, so I've got a pretty bad AKI. And I've got some electrolyte abnormalities as well. Because I'm unwell, you decide to take a lactate, which is 3.9, which is up. And the CRP is elevated as well. So basically, the clinical picture overall is a bit concerning for this person, isn't it? And then these are the LFTs. Does anybody want to take a stab at what they show?
Obstructive picture again.
Yeah, good. Obstructive picture. So you've got a Billy, which is up. You've got a GGT and ALP, which are both up. And you've got ALT and AST are both up as well, but the predominant picture is a cholestatic one. Okay. So that's sort of what cholestatic LFTs in cholangitis would look like if you see them. Perhaps even worse than that. Yeah.
Would you need to do anything at this point to be certain that it's not ischemic gut? Because he's obviously got significant risk factors for it. He's currently in AFib as well. His lactate's elevated.
Yeah, no, that's a good point. It's always really
I've not got a history of 3 days, so that makes it, I think, a bit less likely, but
yeah. That's a very good point. Generally, if he's taking his anticoagulation, it might be a little bit less likely, but anybody with AF with such a significant cardiovascular history, you'd always have to think about that. Generally, with mesenteric ischemia, what you sort of, and I personally haven't seen a case of mesenteric ischemia in person, but generally what you would expect is symptoms which are out of proportion, symptoms described which are not reflected in the abdominal exam. So generally the abdominal exam is relatively benign compared to the severity of the symptoms that the patient describes. So I think in this case, he's sort of clinically jaundiced and he's very, very tender in the right upper quadrant with guarding. So I think that it sort of would lead you more towards ascending cholangitis rather than mesenteric ischemia, but I agree that the lactate of 3.9 is quite concerning as well. But yeah, no, it's a very good point, and you would definitely think about it in any sort of acute abdomen like this. But I think the overall picture leans more towards cholangitis rather than mesenteric ischemia, if that makes sense. But I think it's a very valid differential to bring up, and I think if you were an ED and presenting this case to the consultant, you would mention that you've thought of this, and you would let somebody more senior than you say, no, I don't think it is that. I don't think we need to worry about that. Yeah. So in this case, you've got ascending cholangitis, but not only that, you've got sepsis as well. The patient's very unwell. So I put together this table to sort of just try to simplify things a little bit. So this is just comparing the 4 sort of main gallstone syndromes. So with biliary colic, which was the first case, you get right upper quadrant pain because you've got the gallbladder, you've got the cystic duct obstructed by a gallstone, but there's no inflammation, there's no jaundice, and there's no obstructive LFTs. In the second case, which was choledocholithiasis, you've got the gallstone sitting in the common bile duct, but there's no infection, there's just obstruction. So you've got right upper quadrant pain because you've got an obstruction there. You've got jaundice and obstructive LFTs, but there's no raised white cell count because there's no infection. Acute cholestasis was the third case. In that case, you've got right upper quadrant pain, a raised white cell count because of the inflammation, but there's no obstruction in the common bile duct and to the outflow of bile. So you've not got no jaundice or obstructive LFTs because the stone's sitting in the cystic duct. And then with ascending cholangitis, you've got all of it. You've got infection, obstruction, and pain as well. Does that make sense as a summary? Cool. So in terms of how to approach it, basically with any right upper quadrant pain, the first thing you're going to do is an abdominal ultrasound, and that's sort of the common answer for all of them. With biliary colic, you'd expect to find stones. You get acoustic shadowing posterior to them because the sound waves can't pass through the stone. And the easier thing is to just look up on radiopedia what that actually looks like. If you get the patient to move during the ultrasound, the stones will also move, so they move with gravity. You might also see sludge as well. And if you need further imaging, you can always do an endoscopic ultrasound as well. And the management will be really case dependent, whether you sort of watch and wait or you do an elective lap chole. With choledocholithiasis, you do need to actually address it. So the first thing again is an abdominal ultrasound. The main difference here is that you might actually see a stone in the biliary tree rather than in the gallbladder. And you might see dilatation of the biliary tree above the stone as well. I think there's a chat here. If the patient is very high risk for a stone, that is, you're almost certain that there's a stone without sort of knowing for sure, and there's cholangitis present, you just take them straight to ERCP generally. But if you're sort of a little less sure, ERCP is obviously not a risk-free procedure. There's a risk of pancreatitis and other complications with it. So if you're not dead certain that you're going to find a stone, it might sometimes is safer to do an MRCP or further imaging to make sure, and then go to ERCP later if you need to. And if you're having troubles with choledocholithiasis, sometimes you're going to need to consider a cholecystectomy as well. With acute calculus cholecystitis, you get some specific signs. You get gallbladder wall thickening, fluid around the inflammatory fluid around the gallbladder, and you also get a sonographic Murphy sign. So you can put the probe on the gallbladder, get the patient to breathe in, and when the gallbladder touches the probe, they'll stop breathing. If basically you can't confirm the diagnosis this way, you can consider a nuclear medicine scan, which is basically a radioactive dye that can get taken up into the liver cells and then excreted into the biliary tree. And if it's not sort of going into the gallbladder within 30 minutes, you assume that the gallbladder is blocked by a stone and the cystic duct, and that's a positive test. The management is analgesia, fast, IVT, VT prophylaxis, and manage the comorbidities, and antibiotics until the cholecystectomy is done, and then you can stop the cholecystectomy. Okay. I don't know when. Steve's just asked me if I can wrap up soon, so I'll just try to race through this a little bit. Generally, with upper GI antibiotics, it's amoxicillin and gentamicin, unless there's septic shock, in which case you add metronidazole as well to cover your anaerobes. And then with ascending cholangitis, it's much the same, except you just need to manage the sepsis. So look up sepsis 6, which is oxygen, put in an IVC, take out bloods, give fluids, take cultures before you give antibiotics, and then give antibiotics early. The abdominal ultrasound will show much the same as with choledocholithiasis. So you get biliary dilatation, but you also might see the underlying etiology, which might be an obstructing stone or a tumour. You'll need source control, so you need to actually drain all the pus, and an ERCP is the right way to do that. And in terms of other management, again, it's fasting, analgesia, fluid, and antibiotics as well. The difference is with ascending cholangitis, you generally need a more protracted course of antibiotics. I was also going to discuss pancreatic cancer, but I think we've probably run out of time. I think the next speaker is here, but I'll give you all the slides so that you can have a look over the case. The case is written in the notes, so you can have a look at them as well and go through that. Does anybody have any particular questions about anything that we've gone through? No? Cool. All right. Well, thanks for participating. I'll make sure the slides get to SEBA so that they can be sent out to you guys as well. And you can just have a look over the pancreatic cancer case. Cool. Thanks, everyone.
Thanks so much, Tom.
Thank you.